So good evening and welcome to our next SAGES webinar. I did want to go over a few housekeeping items before we start. So SAGES stands for the Society of American Gastrointestinal and Endoscopic Surgeons. And we would encourage everyone who is out there who is not yet a member of SAGES to become a member. There are many benefits of becoming a SAGES member as detailed on this slide. The vision of SAGES is to re-image surgical care for a healthier world. The mission of SAGES is to innovate, educate, and collaborate to improve patient care. There are many values of SAGES, the most important of which is the unofficial value of fun, which I think everyone on this panel can attest to at the annual meetings for SAGES. There are many different types of membership categories for SAGES, including active, candidate, and medical students. And after this session, we would encourage you to go to the website to find out more about membership. This webinar entitled Transition to Practice is co-sponsored by the Association for Residency Administrators in Surgery, and we appreciate their collaboration with us. So we are going to move on to the panel part of this webinar. We are going to try to stay on time because I think the question and answer part at the end is going to be very beneficial. I would like to thank all the panelists who I will introduce as we start, but many of them are sharing their own raw and personal experiences, especially with things that many of us we find out are important in terms of transitioning to practice, but we often don't talk about them. So we hope that this is a very helpful session to those of you listening who are getting ready to transition from training into your first job. So to start us off, Dr. Ehlers is going to start, and she is going to be talking about academic medicine nuts and bolts.
Great, thank you so much. Get my screen up. All right, so thank you, Dr. Haskins. I'm Annie Ehlers. I'm an assistant professor of surgery at the University of Michigan. So decidedly a very academic place. So I'm going to kind of share some of my experiences with that. No disclosures other than much of this is really based on my personal experience. There's not a lot of data, I would say, about how to become an academic surgeon. But I will say I co-chair our faculty recruitment committee, so I do have a lot of opportunity to meet tons of academic surgeons, and so a lot of it's based on that also. So I think kind of the first thing that I always wondered as a medical student and as an early resident was, what is an academic surgeon? And I definitely think early on I had this vision of, you know, it's someone like very famous who operates all the time and they do basic science and they're an amazing teacher, but it was kind of like this very singular vision of what it might be like. And I was like, oh, I don't know if that's necessarily for me. But as I went through residency and training and really got to know different people and understand different things that they were doing, it really opened my mind and showed me that being an academic surgeon really just means that you work in a hospital where there's probably residents and you do something else besides be a clinical surgeon. So I think that applies to many of us. So I think when you're first thinking about if you want to be an academic surgeon, it's really doing some introspection about who do you want to be, or what really interests you about being in academic surgery. There are many different phenotypes, kind of like I alluded to a few slides back. So it's not just sort of that like triple threat that we used to hear about all the time. There's academic surgeons who focus on quality improvement. So, you know, outside their clinical practice, they're running quality improvement efforts either within their hospital or, you know, in Michigan, we have these huge quality improvement collaboratives across the state. And so people really make a career out of figuring out how do we make surgery safer and higher quality for our patients. There's also certainly people who focus on education, both in sort of the role as either a fellowship director or a program director. And I think even more formally, people are turning education into a research career to think about how we can really formalize what we've learned. Similarly, global health is obviously growing, tons of interest and people are making careers. And then of course, there's sort of the traditional path of research, either basic science, outcomes, et cetera. So I think as you start to think about like, what do you want to be, then, you know, you can start to think like, are there certain things about this that interest me that I might be trying to prepare for? So really, and I apologize in advance if you hear a toddler in the background, it's bedtime over here, but so I think first, how do I prepare? I kind of boiled this down to 3 main things, and I certainly don't think this list is exhaustive, but they kind of capture a lot of the different things that I found very helpful when preparing for an academic career. So first is to find a mentor or many mentors. So these are just a handful of the mentors I had in residency and fellowship. You'll see Dr. Wright on here, who's actually going to be speaking later. But I think that when you're thinking about a career in academic surgery, it can really help to understand and talk to real people who are doing it to see what is their life like, what is their practice like, and what are the different types of things they're doing. So from this group of mentors, I had some of them who were very clinically busy surgeons. So I got to kind of learn what is it like to be basically, you know, a clinically active surgeon who does administration, or some of these were very heavily research focused. So understanding how do you apply for grants, how do you write papers. Some of these were quality improvement. And I think also importantly, they all had very different clinical practices. So kind of understanding how you might work that into your future career. And I think importantly, it also gives you the opportunity to, as you're going through this and thinking about what kind of surgeon do I want to be, how do I want to fit into academic medicine, they can really serve as sort of sounding boards for you. So the next thing I would talk about is build your CV. And I think that this sounds obvious and kind of dry, but I think there's a couple of reasons outside of the typical that you might think of. So when I was first thinking about building my CV, really the only things I would say as a medical student or junior resident that I thought would go on there were maybe like publications or presentations. So if it wasn't perhaps a manuscript or a book chapter or something that I presented at a meeting, then maybe it didn't belong in there. And I think A, that's probably a misguided assumption that I had, and B, it sort of limits, you know, the types of things that you might be able to share about yourself when you eventually use your CV to apply for jobs and things like that. So other things that I would include on a CV would be quality improvement projects. So I think most of us in residency participate in some sort of project, whether it's on the wards or within your residency program. Any leadership roles you have. So whether it's being the admin chief or running, you know, a journal club or something like that. Any committee work, service work. So if you're participating in mentorship activities with medical students or other residents. And finally, you know, work in professional societies. So one of the most rewarding things that I did as a resident was participate in different organizations like SAGES and American College of Surgeons. And not only was it really fun and informative, but, you know, it was a great CV builder. And again, I know this can sound pretty boring, but I'll say in kind of one of my roles of interviewing faculty for different jobs, what we first get really is someone's CV. And that's how we're kind of figuring out who might fit into a role. And so we are never going to know about all the amazing things that you've done or all the amazing projects that you've done unless it's really on your CV. So thinking about updating that early and often. And I think, you know, the CV can really be kind of your intro, but once you land the job interview or you know, get that professional partnership that you're looking for, really thinking about how do you hone your communication skills so that kind of your best foot can go forward. And kind of a classic example around this is thinking about, you know, how do you write a manuscript? But I would argue that writing a manuscript kind of helps you understand what do you need in order to clearly communicate. So how do you kind of figure out the ways that you can maybe tell the story about who you are and why you deserve to be an academic surgeon? Because I think so much of being an academic, fortunately or unfortunately, is really being able to sell who you are so that other people want to collaborate with you, hire you, be your mentor, et cetera. And so one kind of first way to do this, I know some of us might be at different phases of residency and things like that, but one first way that you can do really at any stage of your career is think about what your elevator pitch would be. An elevator pitch, I think, is something that we talk about in probably many fields. It's certainly not specific to medicine. But I remember, when I was in the research lab, my mentor would often be like, okay, you've got this project. What's the elevator pitch? Like, how would you, if you had 2 minutes in an elevator with someone, how would you sell your idea? And I think that it can actually be something you think about for yourself at different stages. So if you are, a 4th-year resident thinking about, or 5th-year resident and thinking about fellowship or job opportunities, really writing down, if you had just a couple minutes with a future employer or someone you wanted to work for, what would you say about you? So who are you? What are you interested in? What is your long-term goal? So clearly, maybe you want to be a colorectal surgeon, but your long-term goal is to design and build clinical trials within colorectal surgery. And I think, this was very intimidating for me. It still is intimidating to me, because it's like, well, what if I change? Or what if this isn't really who I end up being in 10 years? I think that's okay. I think that this kind of goes with the communication skills and showing off what you've been able to accomplish. And it helps people understand, like, okay, you have a vision for yourself, you have goals, and you've kind of thought about how you might get there. So something to think about. And so I think this leads obviously next into, you can't be an academic surgeon unless you can get a job as an academic surgeon. So this was something that was kind of a black box to me. I remember as a resident, and I definitely asked around to a lot of different people and kind of just anecdotal experience. And unfortunately, this actually is an area where I found a little bit of data, but I would say, kind of first things first, ask your mentors. So going back to finding kind of a team around you, either in your own institution or more broadly, to, do they know anyone who's hiring? That's how I found my first faculty job, actually, is Dr. Wright helped me find it. So looking on job boards. So SAGES has an incredible job board. It's not just for MIS. There's lots of different jobs on there. Or ACS has a great job board. And then if there's other sort of subspecialties, most of them tend to have some kind of job board where they're updated pretty frequently and can give you leads. And then, of course, kind of networking at meetings, things like that. So these were kind of the 3 top things I thought of. But interestingly, I was able to find some data. This was a paper where they surveyed people who had graduated from colorectal fellowship that had landed a job, and asked them, what were kind of the top things you used to guide your job search. And, some of the top things were pretty obvious or not surprising, like looking at job posting on Askers, asking your program director or another person you work with. But you can see there's a lot people use recruitment agencies, a lot of different ways to find a job. And then thinking about timing for it. And I would say it was pretty true to form for most people that I knew, and also kind of the heavy interview cycle that I think of now, is that most people are kind of thinking about offering those first interviews to candidates in the fall or winter. Because especially when we think about hiring new faculty, everybody knows that you're going to be ready for that first job probably in like September or October following completion of your fellowship year. And so trying to think about blocking off some time, in the late fall or early winter can be really helpful for you, especially because fellowship can get pretty busy when you're taking your boards, or even your chief year obviously is very busy because you're trying to sit for boards and tie up all the loose ends you need before you go into practice. So then I think in the last few minutes, just thinking about how then should you prepare I've done all these things. I've spent my whole 5, 6, 7, 8, how many years of residency preparing to be an academic surgery. I have this job interview. How should I prepare next? Again, not to go back to this, but update your CV. Think about how is this going to present to a potential employer? prepare a one-pager. So this is sort of an extension of the elevator pitch, but your CV is pretty long, it's pretty boring. Most of them look the same. But I found that it was very illuminating to potential employers when I was able to also provide a sheet that said, this is a little bit who I am. Here's sort of how I've integrated my clinical and research interests to date. Here's what my goals are. I've even thought of some maybe funding sources, and here's where I expect to be in 3 to 5 years. So that kind of gives someone a very crystal clear vision of who you are. And then importantly, kind of understand the interview format. So I think that kind of speaks to itself. But I think, and this is one of the last things, is really, I haven't mentioned this too much, and I think some of the other talks are going to go into this, is thinking about what do you want. So a lot of this is obviously pretty cut and dry of, doing the work and showing that you're prepared. But this is also the first step in hopefully a very long career for you. And so I think taking a careful look at what kind of a job you are interested in, because it could be, the most prestigious institution in the world that's asking you to take a job there. But if it's not the case mix that you want, or they're not providing you any protected research time, the call is really unfortunate, it's not in a place you like, then you're probably not going to be happy. And then just to finish up, I think this was another, one of the other few papers that I found thinking about this. This was focused on being a surgeon scientist, but I think you could really just say, how do you find success as an academic surgeon? And it's really, again, when you're looking for that first job, thinking about how you're going to be supported in terms of mentors, social support, what's the environment like, something we often don't talk about, what's the salary going to be like. I know we're going to talk about in a later session, but really thinking of all the pieces, because you have done all of the work and you deserve to get a job that you really like. So I think we'll wrap up there. And I think just in summary, there's clearly not one way to success. There's lots of different ways to be an academic surgeon. Finding mentors, I think, is one of the most critical aspects. And then along the way, just being yourself can really help you, I think, stand out not only from kind of the others around you, but it's also going to help you, I think, find the most impactful and fulfilling job for you long term. Thanks so much. And I look forward to hearing the other sessions.
Thank you, Dr. Ehlers. That was great introduction to academic medicine. And I grew up in Michigan, so certainly go blue. I'm impartial to you. So next up is Dr. Halbert. She's going to be talking to us about community and practice, private practice medicine.
Great, thank you. Thanks everyone for joining tonight, and shout out to all those who are interested in SAGES, because it gives an opportunity like this, which I'm very thrilled to have. So no real disclosures. I get taken out for dinner once in a while, but nothing that contributes to tonight's talk. We're going to talk about what is community practice, because there's a lot of confusion over what it is, believe it or not. What are your expectations for practice? And then one of the really important things about community practice and where the shifting tides are is a really push towards physician leadership. So we're going to talk a little bit on that and how that can help with promotion within community practice. So first, let's define what community practice is, because you can't talk about it without defining it. And this is going to be the most vague definition, so just be aware. But the Community Practice Committee at SAGES came up with this definition. A community practice surgeon represents physicians providing care outside of tenured academic medicine. They are trusted leaders of the healthcare team, focusing on the care of their community. A community practice surgeon includes general surgeons and surgical subspecialists. They are located in rural through urban centers, working in hospitals of various size and capability. Now, caveat to that is that it's all a gray zone. So the things that you just heard in Dr. Eller's talk apply a lot to community practice surgeons as well. And a lot of what I'm going to talk about also applies to academic medicine. And especially when we have these large groups of healthcare centers buying up other hospitals, and they're buying community hospitals, and it's academic, and the lines are blurred. So we all kind of do the same similar things, but there are some nuances that I'm going to talk about tonight. So there's all these misconceptions. We're going to attack each of these and really talk about them, because what community practice surgeons are not is OSH, outside hospital, right? So we are the hospital, we are the community taking care of patients, and there are certain things that that define us and certain things that do not define us. So we are highly skilled surgeons. A lot of us are Renaissance surgeons who do everything from breast cancer to colon cancer to colonoscopies to thyroid. So, you know, just really run the gamut of all different types of surgeries, especially those of us who are in more rural areas. But we also include a lot of subspecialists. I'm MIS Advanced GI bariatric trained, and I'm in a community hospital. And actually 70% of fellowship grads are going into non-academic centers to work. So that's a significant workforce is going into a non-academic center. We also participate in research, believe it or not. The thing is, though, that our promotion is not necessarily based on research in a lot of our job specs, but a lot of us can participate in research. I have research ongoing at any given time. A lot of my stuff is more clinical. I don't do bench work. I don't have time for bench work, but I do research, and a lot of my colleagues do as well. We also participate in not only local chapters and organizations, but also national organizations. And I'll talk a little bit about things that I participate in as an example. So what else? So we are, members of our community. So we're not just the surgeons necessarily working out of the hospital, but a lot of us are really engaged in our communities. And we tend to really find roots in our hospital's community. And we don't typically move around. Now, again, that a lot of times will apply to academic surgeons as well. But we tend not to jump around from hospital to hospital, moving our way up. We tend to work within that hospital system. We are involved in a lot of philanthropic endeavors, advocacy. One of my focuses has been food deserts in our urban centers. We educate our community through various ways and do a lot of outreach for our high school students, middle school students, things like that. So we do a lot more outside of our clinical work. So what kind of practices are there? So, the introduction to talk about private practice, but that's just one caveat of community practice. And private practice is super variable. It could be a single surgeon that puts their shingle up like this old shingle, and start their surgical career that way in their office. That's actually that's starting to go the wayside because it's a very expensive endeavor to pursue. So a lot of folks are actually working as a small group or a large group, a multi-specialty group, if they're in private practice. Those folks tend to be affiliated with hospitals that they operate out of, possibly an ambulatory center that they may even co-own. And then community practice also includes hospital-employed surgeons at community hospitals. I've had a history in both of these different types of practices, and they both have their unique challenges and opportunities. A lot of us also work at independent academic medical centers. What is that? That's what we call the hybrid model. So we have residents, but we're not an academic institutions. We have 31 residents at my institution, but we are not an academic center. We're considered an IAMC. As I may have alluded to, we're in all different locations. So rural, urban, suburban areas, we're really all over. Because of this, we can also vary by capability and access. So I love when I hear talks that are like, well, I just got the HPV fellow to come on in and help me out. Well, that's great. If you have an HPV fellow, or if you have IR that's going to put that perk drain in for you, but that's not really everywhere. So you got to be careful about that. Not every hospital system has that. And you kind of want to know those things before you go into employment there. Technology is not equal at every institution. So God forbid, not everyone has a robot yet. It's getting better. Or things like specialists that can do ERCP. Also, the level of care is really important to take note. One of my friends, I was just talking to her, she's in a very rural hospital in Southern California. She used to do Whipples in fellowship training, and she doesn't do any of them. Why? Because she doesn't have an ICU that can really take care of those patients. And so you have to be careful about what kind of procedures you do in hospitals like that that may not have that capacity. What are your expectations? Well, I think this is pretty common for anyone in practice. You need to have good clinical outcomes, right? Obviously. Good citizenship, show up on time, get your work done, sign your notes, do the things that you should be doing. You're going to have some kind of productivity goal. Usually it's RVU, but it may be something else. I used to be incentivized by compensation back in the day. I don't work at that job anymore, but there's different types of way that people are given goals. There are academic pursuits, especially for those of us that are in those hybrid models, or those of us that just want to do it. But teaching, research, things like that may be part of your expectations. Then there's things that may be above and beyond your work spec or maybe part of your job spec. So going through programmatic development. So if you're a program director, obviously that's part of it. And the hospital loves to see, creating new revenue streams for the organization. Quality improvement work that Dr. Eller talked about, super important as well. And you may be asked to work on hospital committees of various types. And your work on national and local organizations is not ignored. That is actually important to the institution because that helps build their brand and also gives you leadership experience. So what kind of leadership opportunities are in a healthcare system like this or in a private practice like this? Well, things that we would think about, right? Section chief, program director, medical director, chair, but then also these other things like director, owner, CEO of an ambulatory center, CEO of a medical group, board of trustees, what is that? So there's all these opportunities that are out there. And I will give you a little hint about mine, just as an example. So it was first in private, I love this picture, by the way. This is like my first year out in practice and I loved operating. So I just put that picture up there just for reference because that makes me happy. So private practice is where I started, but I transitioned to hospital employment 2 years later. Then I became the assistant program director of our residency program and medical director of the surgical advanced practice clinicians. So our NPs and PAs, they asked me to do that. That wasn't a job I was at all prepared to do, but taught me a lot. Because then I went on to become the medical director of our bariatric program and also the medical director of a surgical floor. Again, something I wasn't used to, but learned a lot from. Now I'm the chief of surgery, so I run the Department of Surgery at our Wilmington campus. Because of that, I chair our value improvement team, which is a quality improvement team for our operating room perioperative services, and I'm also on the block committee. And then I'm also a board member of our medical dental staff executive board and on a committee for our medical group. So really variable, I'm not saying this to brag, I'm saying there's so many different things that I was not prepared to do in practice, but I had the opportunity by working at a great organization that really helped promote me and wanted to expand what I did beyond my clinical work. So the pathway to leadership and community practice is really different. It's not because of how, they don't look at my CV to say, oh, how many publications, how many grants did you get? They're not looking at that at all. What they're really looking at is my leadership ability and my experience. And that's very common across a lot of practices, both in private practice and in hospital employment. Because of that, that focus on leadership development, things like an MBA may be important if you're looking into leadership roles yourself in the future. These are some of the topics that I've learned through different programs I've been part of. I was actually part of the Academy, the physician leadership program there on the right. And these are just some of the topics that we learn, which again, are not something you gain in fellowship. This is, or residency or medical school really for that matter. So, so it was really great to take some of these courses and learn these topics. I will also shout out the Brandeis Award through SAGES as another opportunity to garner some education on leadership. And this is just a list of some of the things I think are really important as physician leaders. For the sake of time, I won't go into each of these, but you don't see charisma and you don't see like IQ in here. You see knowledgeable, but you don't see like how smart are you, like your IQ. It's really this ability to be introspective, to adapt, to pivot, and really to be very genuine to yourself. All of those things are really important for physician leaders. And through some of the different courses that we mentioned, you can actually learn these things if you're not really good at them at baseline, but also working with really strong teams and getting the experience. So like I said, I didn't know what it was to be in charge of the advanced practice clinicians, but I did the job and I learned a lot. And I learned a lot of these skill sets by taking on those jobs. So in conclusion, community practice encompasses, first of all, the majority of surgeons across the country and takes care of the majority of patients in our country. It's really important to understand the variety of the practice types that are out there, because you want to find something that really fits your expectations and your philosophy. Advancement nowadays is really based on the quality of our physician leaders. And so you want to do everything that you can to position yourself best as a physician leader in your organization. So thank you very much.
Thank you, Dr. Halbert, for talking to us about community practice. You certainly have added a face and personalization to the OSH reference. And you've really broken down some of the stereotypes that many people have about community practice. So thank you for that overview. Moving along, the next presenter is Dr. Wright, and he's going to be talking to us about road to promotion.
Well, thanks. I really appreciate this opportunity. And I also appreciate the fact that both Dr. Halbert and Dr. Ehlers really set me up nicely. So this is fantastic. I was asked to talk about road to promotion, but recognizing that most folks are going into community surgery, it's not always traditional academic promotion. So I also put in here how to succeed in your first 6 years. And I'll come back to why I said 6 years as a particular frame of reference. I do have a minor disclosure. It's not going to affect this, this talk. So you might be thinking to yourself, why, who me? Why should I be worried about promotion? I'm still just trying to get through residency and I'm just trying to find a job. And I think the reason is you need to understand what being a surgeon looks like, so that when you're looking at jobs and evaluating job offers, you can really make a good decision about where you want to go, what kind of job you want to take. And as Dr. Ehlers mentioned, really talking about crafting what that job looks like. So you might say, why should I care about being promoted? Or, for example, taking on physician leadership roles in community practice. Many institutions actually have an up or out policy. So many academic institutions, if you don't get promoted within 6 years, for example, at my institution, you actually have to leave. So knowing about promotion criteria and how to get promoted turns out to be pretty important. Promotions and or leadership opportunities can also translate into income. Many of my administrative roles actually come with an administrative supplement. So I actually get paid more for taking on new roles, or I might get paid more for getting promoted. But I think more important than either of those two is really about personal fulfillment and thinking about your early career and really your entire career as a period of growth. When you're a resident, you're really focused on like the next day, the next week. When you start thinking about being an attending, it's not just the next case or the next week or the next clinic. You really have to talk about what's your 3 or 5 or 10-year plan and how are you going to continue growing as a surgeon. You come out of residency knowing how to operate, but all of these other things about being a doctor and about being a physician, we never talk about in residency. All the things like leadership and running a value analysis committee and all of those things that both our previous speakers talked about, those are actually great opportunities for personal growth and personal fulfillment. That all comes down to this idea of defining what success looks like for you. And that success is going to look different for different people. There are some surgeons, all they want to do is see patients. They just want to operate. They want to see patients. They never want to attend a committee meeting. That's great if that's what success looks like for you. There are other surgeons who want to spend 80% of their time doing bench research and they want to do only 20% of their time working clinically. If that's what success looks like for you, great. But you need to figure that out for yourself and look at the job opportunities that you have and how, not just what is offered to you, but how you can craft your response to a job offer to really craft that job in the way that you look and like that you want and in the way that you can succeed. I like this slide. You may or may not have seen this before, but it's this concept of ikigai, which is you have to define what you love, what the world needs, and what you're good at, and also what you can be paid for. So if you can find a niche that sits at the center of all of those things, that's what's going to allow you to have personal success. And I'll come back to this concept in a few slides. Speaking very specifically about academic, the traditional tenure track academic, We talked about early career as being an assistant professor. Most people are hired either as an instructor or an assistant professor. And then that first promotion is really the promotion to becoming an associate professor. That really defines what's sort of a mid-career surgeon. And then late career surgeon would be someone who's promoted to a full professor. I think the most important thing when you're looking at a job and a job offer is to know what the promotion criteria are. And every institution has its own promotion criteria. So the promotion criteria at the University of Michigan is very different than the promotion criteria at the University of Washington. So there are written promotion criteria, and when you're evaluating a job, you should actually ask to be given the promotion criteria. So this is just an example. This is our promotion criteria at the University of Washington, and it walks through what the commitments are and what the expectations are of a new faculty. Generally speaking, the traditional clinical model is that triumvirate, the so-called triple threat of the clinical, the research, and the education. I think in the modern world, folks realize that you can't really do all three things well. And the modern academic programs don't really expect you to have equal weighting to these three buckets. The other thing to know is that the traditional three buckets of clinical, research, and education really aren't adequate anymore. And so now our own program, for example, specifically calls out your administrative roles. It specifically calls out your efforts in DEI. And it also calls out professionalism. So these are all of the buckets that go into promotion, at least in my institution. Going through the promotions criteria even further, you can say, okay, what do I need to become an associate professor? So review occurs before the 6th year. You can go up early, but you have to go up by at least your 6th year. And you have to have shown productivity and advancement in at least 2 of the 3 areas of teaching, research, and clinical care. Again, they don't expect you to do all 3. And roughly speaking, you should have a reputation beyond the School of Medicine. So that means recognized in the community as a good surgeon, or recognized nationally, for example, by being a committee member in national organizations. The problem is that this doesn't actually tell you what you have to do to show productivity. And this is really where it's not just the written promotion criteria, but understanding the unwritten rules about promotion at your institution. And this is the kind of thing you should know before you take a job, because if you don't know and you don't meet both the written and the unwritten rules, you may have a different expectation than your boss, and that may set you up for failure. So what do I mean by the unwritten rules? So first off, you may be in a track. So many institutions have like a research track or an education track. My institution actually has a choose your own adventure. There is no research track. There's no education track. Instead, there's a written job description about what your own personal expectations are. And then you are judged against what those expectations are that are set when you're hired. That's actually a fairly unique model, but it's nice because it allows you to craft your own position. But here's what we're talking about, the unwritten rules. You may be on a tenure track position, and at institution A, what that looks like to succeed and get promoted. You might need to write a couple of clinical papers a year. You might be a committee member at a national society, and you might have a role in resident education. That might be enough to get you promoted. Another institution, same job title, to become an associate professor, you might have to have an NIH R01 grant. And if you don't get that grant funding, you're out. If you don't know that when you take the job and you don't know how to craft the first few years in your job, that may be a recipe for both your own personal dissatisfaction and also the institution being dissatisfied with you. So say you are interested in academic medicine and being at a traditional academic center, but you don't want to get a K award, or you don't want to do 3 to 4 papers a year, and you really want to focus on clinical work and teaching residents and being a good surgeon, but not doing all this other stuff. You may, in that case, not be on a tenure track job, but now many academic centers have a non-tenure track clinical faculty role. So this may have different names at different institutions, things like a clinical assistant professor, or a clinical associate professor. This is really where we're seeing the blurring lines between traditional academic models and the community models that Dr. Halbert was talking about. In these kind of roles, when you look at the buckets, the primary thing that you're being judged on is really your clinical activity. And it may also be things like your administrative contributions to the institution. You may or may not do research, but it's really not considered in your promotions criteria. And you may or may not do education, but as long as you're sort of doing the minimum baseline teaching and getting decent reviews and not being mean to your residents, you'll probably get promoted. There is a whole promotion process. I didn't know any of this in my first year in practice, and I was in my first job for about 3 years before my chair sat me down and said, "Hey, how are you doing on your promotion clock?" And I said, "What?" So many institutions actually have a clock. That clock, for example, at my institution is that 6-year clock, and you have to know if you're on track before the clock runs out. Now, you can get extensions to the clock. For example, if you have maternity leave or, for example, COVID, many institutions added a year to people's clock, but the clock will run out eventually. Sometime as you're getting close to the end of that period, you have to put together your own promotion packet. It took me probably 40 hours worth of work to put together my promotion packet the first time. This is actually a huge amount of work to put your promotion packet together. And then that goes up to the promotion committee. And if they approve you in your department, you might get sent on to the hospital or the university promotion committee for approval. So what if you're a non-academic career or non-traditional academic career and you're more in the community surgeon mold? Well, you may not have promotion in the traditional assistant, associate, full professor model, but there are lots of ways in which you grow and may move into new positions. So some of those things are the things that Dr. Halbert talked about, things like, are you running a program? So are you happy just taking care of patients, or do you actually want to build a bariatric program or build a hernia center or start getting involved with hospital administration or become a clinic manager? All of those are really important roles that actually turn out to be very satisfying on a personal level that I didn't think anything at all about when I was a resident. Many programs, if you're in traditional private practice, you might be employed for the first 2 to 3 years, but then at year 3, you may have to either buy into the practice or leave. So that's a different way of thinking about promotion, but you have to think about that and know what you're getting into, again, when you take that job. So just getting back to the idea of all of the different buckets that you have to fill, and then thinking about this concept of the ikigai and finding a way to integrate all of those buckets into what you do. And I think the number one key to success that I've seen for both myself and my personal experience and then in my mentees, it's really about finding a niche. That niche doesn't have to be everything that you do in life, but if you can find a niche, you can build everything else around it. So let's take an example. So say you do a bariatric fellowship and you're taking a bariatric job. What can you take to that new practice that's unique and different and then you can build? So maybe that niche within bariatrics is you're interested in starting up a balloon program or an endoscopic sleeve program that nobody else at that institution is doing. Or say you're a hernia surgeon, you've done an abdominal wall fellowship and you want to start an ETEP program. So you can set that up and that can be a clinical niche. You can then do research papers on that niche. So you look at clinical outcomes of your balloon program or of your ETEP program or whatever that niche is. You can then look at your residents and say, well, what do residents need to know about bariatrics? And you can say, okay, well, I'm going to build an education curriculum around bariatrics. And it turns out at a lot of places, a curriculum counts as much as a peer-reviewed paper on your CV. And then you might say, well, how can I take an administrative role in that same niche? So again, taking that bariatrics example, well, is there a bariatric steering committee that you can join? Can you look at quality improvement around bariatrics where you can reduce length of stay from 2 days to 1 day, and then the hospital is very happy with you because you saved the hospital money? Or can you join the value analysis committee because you're really interested in, okay, which stapler platform are we going to use? So you can wrap all of your roles, those clinical, the research, the education, the administrative, and wrap those all around an interest. And it also allows you to double dip. So the clinical work becomes your research, and the education becomes your research, and the education becomes your administrative. And it really helps you build around your passions and what you're good at, and allows you to get paid for it. I think it is important to know that your goals can change, and my goals personally have changed. When I started practice, I wanted to be a grant supported, have an R01. I wanted to be 80% research and 20% clinical. What I realized after a few years is I didn't actually enjoy that, and I didn't like writing grants. I still like doing research, but I didn't want to have that same level. So I had to go to my chair and say, hey, you know, this isn't working for me, and I need to change my focus. And I was able to actually primarily take on an education role for my non-clinical work. And I also was able to change my clinical work to take on more hernia, and I actually stopped doing bariatrics. So those goals have changed multiple times through my career, and that's okay. I only have a couple more minutes, so a few practical points. Dr. Ellers talked about the importance of mentoring. I think it's important not to think of a mentor as a single person, but really as a team, because different people are good at different things. So I have a person who's really good at education, and a person I turn to for personal advice and support, and folks I turn to for how I get promoted, and somebody I talk to about what it means to be a surgeon in the world. I also think having a coach is different than having a mentor. And lately, I've been actually recommending to a lot of my mentees to actually hire a coach who can really help you analyze and think about what you want separate from the workplace environment. There's a lot of professional development that you can do that I think is incredibly valuable. The Surgeons as Educators course, the CERF Fellowship through the ASE, some research courses, all of these professional development programs are fantastic. Some practical tips. Dr. Ellers talked about the importance of keeping your CV up to date. One of the reasons it took me 40 hours to do my promotions packet is because my CV was 2 years out of date. We don't have a whole talk in this session about financial literacy. We don't really have time to talk about it. I do think it's incredibly important, something I was really bad at when I started my first job. I think it's important to have an advisor for your finances that's paid not on commission, but that you actually pay a flat fee to. I can speak from personal experience. I had cancer and I had to take about 4 months off from my practice. Having good health and disability insurance is really critical. I think it's really important to manage your online presence. Again, we don't really have time to get into the details there, but we can talk about it maybe in the Q&A session. And the number one thing in terms of building your clinical practice is really about referring your providers and having good communication with them. So I think I'm at 15 minutes, so I will stop there. Thanks, everyone.
Thank you, Dr. Wright. Those were some awesome topics and some great practical advice for young trainees and certainly people who have been out in practice. I think we forget that surgery in our career is sort of a lifelong learning experience. So great opportunities that you noted on some of your slides. Moving right along, next is Dr. Prabhu, and she's going to talk to us about what to do when things go wrong, managing complications.
Okay, can you see my full screen view?
Yes.
Great. Thanks so much for having me, Ivy, and to the rest of the panel. This is a really great opportunity, so I really appreciate being asked to do this. And also, I have no idea why you asked me to talk about complications, but I'm going to try to get through it the best I can. I'm actually going to take a little bit of a off the beaten path approach to this, and I'm going to talk about this in two different aspects. One of them is, what do we do about talking to the patient, and how do we manage our relationship with them and what's going on after something terrible happens? And the other one is, what about ourselves, and how do we manage ourselves kind of through this process, which is a horrific one when it happens. So many of you have probably seen this quote here. Every surgeon carries with him, actually, I'm going to just try to move my little thing here, a small cemetery where from time to time he goes to pray, a place of bitterness and regret, where he must look for an explanation for his failures. And I would say that's aptly put. The photos on here are difficult to share, but this is a patient that had a gigantic ventral hernia and also a congenital Morgagni hernia. He's an adult, and his liver was in his right chest for the entirety of his life. And after I took him for a small bowel obstruction, a few years later, he came back and wanted repair of this hernia. And I did it. And afterwards, as you can see, he went into florid liver failure. And it turned out that his hepatic vein was kinked off. And at the take back, you can see that his liver is dead. Needless to say, this patient did not survive. And this is kind of one of the worst ones that I've had that will stick with me for the rest of my life. And I'll come back to that in a little bit. But first, I just want to start by saying, this happens to everybody, and this is the way that it goes. And when you come out of residency, this is not what you're expecting to happen. You've done the perfect operation, you're feeling pretty good, maybe you're doing a little bit of fist bumps, and then suddenly you're back in the operating room with a wound infection or something terrible, and it feels horrific. And so I want to go through a framework for addressing complications head on with patients and talk about the insensible stressors around that, how to right the ship and maintain objectivity where possible. And I also want to just say the vast majority of this portion of the talk is taken from a course called Vital Talk, which I took before. And it is an outstanding course. It's actually mostly geared towards palliative care physicians and medical doctors, but it is useful in terms of talking to patients about bad news, delivering bad diagnoses, and I found it incredibly helpful for when it comes to dealing with surgical complications as well. So the first thing to know is that complications happen to every surgeon, and somebody who tells you that they haven't had complications either hasn't operated enough or they're a liar. But the key in life isn't to go around just trying to avoid complications all the time. And I mean, obviously, well, kind of, it is the key to try to avoid them. But the reality of it is the more you operate, the higher of a chance there is that something is going to go wrong. So more importantly, I think we need to learn how to address them. And that's what I'd like to talk about. First things first, when you meet a patient in the office, that's where this interaction begins. So set yourself up for success when you're meeting the patient and preparing for surgery. It's really important to do a thorough informed consent and documentation. And even though that part of it isn't specific to the complication, it can matter later when the complication occurs. If I'm worried about something that I think we're not going to resolve the patient's pain or some kind of problem is going to persist after surgery, I always put that in my documentation when I speak with them and also in my operative report in the indications for operation. You want to be honest and approachable with your patients and make sure that you're honest with them about your complications. And they might ask you, what's your infection rate? Or how many times have you had to redo a hernia? Or how many recurrences do you have? And I would just be honest with them about whatever it is that's happened in your practice. Because the reality is they're not looking for you to be perfect. They're looking for you to be human and somebody that they can trust. You want to show empathy with them. And it's okay to be vulnerable with your patients. You don't want to come to your interaction with the patient like you're some sort of robot. When a complication occurs, we kind of have this tendency to want to run away. And the first thing I would tell anybody starting in practice is don't avoid the patient. That's one of the biggest mistakes that you can make up front. Go and talk to them personally, talk about what's happened and what might have contributed to it and what you're going to do next. And I'll go through that in a little bit. When I get to the bedside, I usually ask their permission to discuss the plan because usually they already have a mindset by the time I walk in the room, and I'll say, hey, is it okay if we talk about this a little bit and talk about what I'd like to do and what I think is going on? And it's a good way to kind of set the stage. Don't shirk ownership. Don't blame it on somebody else. Don't tell them that it's somebody else's fault that something's gone wrong. You definitely want to show empathy. And if you feel like apologizing, apologize. Now, every hospital has a little bit of a different sort of attitude towards apologizing. Where I work, it's very clear that if you've had a complication, the hospital will support you if you feel like apologizing to the patient. And frankly, even though some of this is kind of medical legal stuff, I like not to practice defensively. I just like to practice like a sincere person. And for me, at least, apologizing feels good in the moment. And most importantly, make sure you tell them that you're not going to abandon them. The biggest thing patients are afraid of is that you're going to run away when things go wrong. And you don't want to be that person. So I'm going to go through assessing the goals of care or addressing the goals of care with this acronym called REMAP. And again, this is all from Vital Talk. And I would highly encourage anyone who has the opportunity to take this course. And we'll go through each step of it. But R is reframe why the status quo isn't working. E is expect emotion and respond with empathy. M is map out what's important. A is align with the patient's values. And P is plan to match their values. So I'm going to go through each step, what you should say and what you should do. And if anybody wants these slides or if they would be useful, I'd be happy to make them available. So step one, reframe why the status quo isn't working. So when you go in the room, I think it is very helpful to say to the patient, like, okay, we know that we're in a different spot. Something has happened. We know that you're having a complication now. And given this news, it seems like a good time to talk about what to do. We're in a different place. So basically what you're doing is setting up an inflection point to say everything had been going according to plan. And now suddenly we're a little bit off the rails or in a different direction than what we expected to be. The next one is expect them to have emotion and respond with empathy. And make sure you name the emotion. So the patient might lash out at you, they might cry. There are a lot of different ways for people to respond. Perhaps they're very quiet in the moment. And I think in that moment is a time for you to say, this is really hard. And is it okay if we talk about what comes next? But make sure that you also are able to call out that emotion. So if they are quiet, say, tell me how you're feeling. Are you angry? Are you upset? Are you afraid? Tell me what's the biggest thing that's on your mind right now. And then acknowledge that. Tell them, I can see you're really concerned about X, Y, and Z, or tell me more about that. Because you want to meet them where they are and you want to invite them into a conversation with you about it. After that, you want to map out what's important. So given this situation, what's the most important thing for you? Or as you think towards the future, what concerns you? Most of the time, I'll be honest, it's not going to be even what you expected it to be. It's often that they're worried that they're going to miss their daughter's wedding or that their dog is at home and nobody is taking care of their dog. It's going to be something like that much of the time. Or perhaps it's that they're worried that they're going to be debilitated for the rest of their lives. But this gives you an opportunity to get the patient to tell you what's the most important thing so you can address that thing with them. Align with their values. So it sounds like the most important things are, or I know you're looking forward to getting back to X, Y, and Z. I recently operated on a guy whose most important thing was he wanted to get back on his motorcycle, and he had an ileus and it took a little bit longer to get him out of the hospital. And we had a conversation about getting him back on his motorcycle. We can talk about the trauma aspect of that later, but I think it's important to be able to name out loud what the patient's values are so that they understand you're on the same page with them. And then finally, plan to match their values. Okay, I know that your daughter's wedding is coming, so we're going to do the very best we can to get your home care set up, get the things that you need in place. And if we're at all positioned to get you there, we're going to do that on time. And you may not be able to meet them where they are, and you might not be able to get them to their daughter's wedding, but perhaps in that moment you say, okay, well, we know we're trying to get you out of the hospital, but here are the things that we can do to help you. They want to know that you're going to meet them where they are and help them with whatever that is. So for that part, a few pearls and pitfalls. First of all, move in closer when complications happen. It's really hard for people to be unforgiving when you're up close, but we've all been in that situation where you just want to run away. You don't feel like rounding. You let the resident handle it, whatever it is. And I would advise you to steer clear of that. I think it's a mistake. Make sure you name the emotion with the patient, especially if it's a tough conversation. The harder the conversation is going, the better the patient will feel if they know that you understand where they are emotionally. And it will also then help them be open to what you have to say. Say what the goals are out loud. Make sure that they understand that you understand that they have certain criteria or priorities that they're trying to get to or meet, and make sure you meet them there. And then finally, make sure you tell them the plan to get to the goal. People feel better when they know you have a plan. They don't expect you to resolve every single thing, and they know you're human, but they're often much more happy once you leave the room with a plan in place. And finally, ask how they feel about it. Make sure you say, like, are we good with this? Do you understand? Is there anything else that I can do? And give them a chance to air any unspoken concerns. So that's it. That part of it. A couple more things here. So make sure you're aware of insensible stressors and make sure to ask about them. And as I mentioned, their stress might have little to do with you. So every once in a while, you'll come across a patient who is still disgruntled, and you might say, is there something else going on? And often there is an outside stressor having to do with bills or some other thing. Don't assume you know how they feel, because we've never really been in their shoes for most of us. So make sure that they understand that you're not making an assumption about their emotion or their opinion or their perspective on the problem. And then finally, don't forget to follow up on your conversation. If you have a talk with them about something specifically complication related, make sure you come back later or the next day to check in and make sure that things are okay, because nothing looks insincere like forgetting to check in with them. So that part, that's the what do we do? How do we talk to the patient part? And then this part is the managing yourself part, which I think can be some of the hardest stuff that we do. And we often do it in silence. So there's this quote that many of you may have heard, which is, when the abdomen is open, we control it. When the abdomen is closed, it controls us. And I put that in here specifically just to say you can set yourself up for success often in the operating room. So we all have a tendency after a long, hard day to not want to struggle a little harder to make our operation perfect. And I would tell you, the moment that you're there is the moment to fight it out and stay and try to do all of your post-op care in the operating room. And what I mean by that is set yourself up for success, fight for that little extra bit to take the tension off your anastomosis, whatever it is you're trying to do. That's your chance and that's your moment. Because after you're out of there, things only get harder. Recognize that complications happen to every single surgeon, and you might feel bad about them, but they don't mean that you're a bad surgeon. It just means that you're gaining experience. Make sure that you debrief with somebody. You have to talk about your complications with a trusted advisor or peer or friend, and don't talk to someone who's just going to tell you how great you are. This is the moment where you got to go through it and you got to say the hard things. And sometimes it's that you should have done something. It's almost always that you should have done something different or done something better. But to me, if you don't do that, the greatest disservice to the patient is losing the lesson. So as bad as you feel, if you can't take a moment to reflect on it and figure out what you would do differently next time, then the lesson is lost, and that would be tragic. So careful with who you pick for this. Pick somebody that you trust and that you can really be vulnerable around. Good judgment comes from experience, and experience comes from bad judgment. Don't stop operating. When something like this happens, I think we all have a tendency to want to run away and not go back to the operating room. And that's the worst thing that you can do. Go back, do it again, do another operation again, do it again and again and again and again. And eventually the sting starts to come away. But I think to sit it out will only make the problem worse. We all also have a tendency to, I used to, early in my practice, I'm almost 15 years out now, but early in my practice, I used to just be quiet when I had a complication. I didn't tell anybody about it necessarily, particularly my family. And what I've learned over time is the more I share with them, the more I tell my kids and my husband, I have a patient in the hospital that's not doing well, I had a bad complication, or I spend time with my dog. Those are the people who have my back. They support me. And when I'm not having a good time, they're always there to support me and help me through it. And I feel so much better when I'm not isolated. And my recommendation would be to engage those around you who do love you. And the final thing I have to say, the penultimate thing I have to say is don't forget about self-care. For me, self-care is all about exercise and running. I really like to run. And sometimes I imagine myself just running all the way away. Don't stop doing whatever it is that makes you feel good outside of work. You should not punish yourself in silence and solitude when things don't go well. I think the best thing that you can do is treat yourself with a little bit of kindness and give yourself a little bit of grace when things aren't going well. And the final thing I have to say, going back to the beginning of my talk, first of all, everything is going to be okay. It's hard to have complications and they never really do leave you. But the last little bit is, and this may sound crazy, but don't forget to take pictures of whatever happens or video it or do something with it. Because I think we all have to share with each other as we move along. This is why we're here to help each other. And part of that is showing people where we didn't do it right. And that feels like the worst thing in the world when it happens to you. But I would just say my pictures of my failures have been other people's lessons over the course of my career. So even though it might feel brash or inappropriate, try to remember that later when you're feeling more objective about it, you may want to share those with somebody. But always make sure you reach out to somebody, take care of your mental health, and hopefully you got some pearls of wisdom from this that might help you when those complications do occur. Thanks for having me.
Thank you so much for that talk, Dr. Prabhu. That was so insightful and very helpful because complications happen to all of us. So moving along, I think I've heard like 3 or 4 iterations of the next talk, and this is the most abbreviated version, so I'm very excited for it. Dr. Greenberg is going to be talking to us about work-life balance. Is it possible?
Thank you, Dr. Haskins. And Dr. Prabhu, thank you for sharing that. Sharing, I think, some of your personal complications is always, I think, some of the most challenging but most incredible things that we can do as surgeons, and we can all learn from that. I personally, in my work-life balance, exercise has very little to do with my wellness, but I will discuss that a little bit too. But thank you again for an incredible and really inspiring talk. So these are my disclosures. I do talk about both myself as well as my wife. I have nothing to disclose that's relevant to this talk. My wife is the medical director for the Academy for Surgical Coaching, and I do talk a little bit about that, but she takes no salary for that, so I don't really see the conflict. But I do have a disclaimer, and that at the end of the day, I think it's critically important to remember that we have the best job in the world. Being a surgeon is really a unique honor and a privilege, and we get to do good for ourselves financially and personally while helping others. And there's not a lot of jobs that really have that, and we help people in a unique and very impactful way at their most fragile of moments. So it's really critically important to remember that no matter how bad things feel, like, we are doing good. That is our job, and that job is truly remarkable. I like to make this talk as very intentional and purposeful as I can, but this is what works for my family and myself. It may not work for everyone, so you need to figure out what works for you as an individual, and you need to figure out what works for your family, because those are the most important sort of units of people in your life. So I remember kind of coming up in surgery and in life and seeing every work-life balance talk presented as this, as a scale, that when one goes up, the other goes down. And I think that's wrong, because to me, work is part of life, right? They're not divorceable. They're completely intricately locked, and you can't have one kind of move without the other. So I tend to think of this sort of more as a sphere, and that I can fill my sphere with about 4 different things. I can fill it with work. I can fill it with my family. And by family, I specifically mean my children, because my spouse is separate from that, because those are 2 different relationships and you have to nurture both of them. And then I can fill it with things that make me feel good, so myself. And when work gets big, it crushes everything else, right? It can close out everything else in the sphere, and you have limited time to do the other things with the other important people in your life. And similarly, when my wife and I had our first and second and third kid, family ballooned in importance, and it crushed out other things like our relationship with one another and our ability to do things for ourselves. And so the key is finding out what combination of, to me, these 4 critical things make you tick and make you happy as a person. For me, honestly, it looks a lot like this. I devote probably the majority of my time during the week at work. And that's probably where most of us are, right? If you just look at the number of hours in a day that we spend the majority of that time at work. I try to then fill the rest of that time with family. So I go to my kids' sporting events. I try to be present in their lives. We help them with homework. We do all those things that you need to do to be a successful and good parent. And then with the little time that we have left over, I focus on my wife's and my relationship, and then a little bit on my relationship with myself. But that, for the most part, has needed sort of the least amount of time for me to be happy in this equation. And so the key is kind of figuring out what value or what percentage of your time you want to spend on those 4 different things for yourself. And I think that is key to figuring out how you make work and life balance together in your own life, because again, they cannot be separated. They're part and parcel of who you are as a professional and as a person. So this is how we do it. So this is my wife. My wife is the chair of surgery at UNC. She's the medical director for the Academy of Surgical Coaching, and in the past, she's been a chair at the Medical College of Georgia, directed the Wisconsin Surgery Outcomes Research Program and the Surgical Collaborative of Wisconsin, and is a past president of the AAS. So she is a baller. And honestly, like, her career is on a very different trajectory than mine. And we have made a lot of our decisions as a family based on her career and her career opportunities. I am an associate professor of surgery. I was just recently hired to Duke, where I'm trying to build a hernia center and build a rural general surgery residency program that we are trying to build as sort of like a competency-based surgical training program. And during our time in Wisconsin, I was the program director for the general surgery residency there. So two very different sort of career goals and trajectories. But again, to Dr. Ehler's point, like, there are multiple different ways to be successful in academic surgery, and finding what inspires you and what your passions are, I think, can help you dictate what success means to you. We have 3 kids. So our oldest, Kate, is now 15. Maya will be 14 at the end of the month, and our son, Brecker, is 9. And they're thankfully look mostly like their mother, which is good for them. At work, we have very different jobs. So my focus right now is sort of on our division and on work within this division of minimally invasive surgery and for education. So my goal is to build clinical work to try and build a hernia program. I focus a lot of that work around resident and fellow education and trying to give them opportunities to learn MIS techniques in both bariatric and hernia surgery, and working to marry some of the research that I've been doing in competency-based residency programs into building one in actuality. I operate usually about 2 days a week. Sometimes it bleeds over to an extra case here or there. To do that, I have clinic either 1 or 1.5 days a week to try and fill that time. And the rest of that is spent in administrative and research time. In terms of extra clinical or call responsibilities, I have about 1 week in every 6 of bariatric call because there's 6 of us in our program. And then I cover ACS call at the hospital, where we do most of our surgical work about 3 to 4 days a month. So if you're on for a weekend, that usually covers most of it. If not, you have like 3 call nights a month, and it's not too bad in terms of clinical responsibilities. My wife's focus is all on the department, right? She focuses on clinical operations, building research, building education. Not surprisingly, her job is very heavily administrative, and so her clinical time is lower. And so she operates maybe a day a week and sees maybe a day a week worth of clinic. She's a breast cancer surgeon, so 1 day of clinic usually will fuel about 1 day of OR. But she spends almost the entirety of her week in meetings. And those meetings are about research, they're about mentorship, they're about clinical programs. She does take some breast call, but has no general surgery call responsibilities beyond that. And breast call does not require her to really come in and do any extra clinical work most of the time. In terms of our childcare, we've used many possible solutions over the years. So when I was still a resident and she was already on the faculty, we initially had our daughter in daycare. But we found very quickly that she was basically like a single parent. She had to do all the drop-offs, all the pickups. She was a practicing surgeon. I was an absentee father as a resident. And so once we got pregnant with our second kid, we very quickly switched to having a nanny. And we have found that we have needed sometimes 2 nannies. We need an incredible amount of flexibility because they have to work more hours than a lot of nannies want to work. And if you try to do the au pair route, you may have to have some other backup plans too, because again, our hours as surgeons are not really conducive to those of either an au pair or a standard nanny. So sometimes we've had nannies that worked Monday, Wednesday, and Friday, and one that worked Tuesday, Thursday, or we've found ones that we just honestly overpay and pay to keep them happy so that they will be very flexible and be willing to work our hours. We have always paid them a set salary and then paid them overtime. We don't want to pay them for hours because if we can get them home early and we can be there, we try to. But if we need them to stay late, we want them to be flexible. So we want to keep them happy and pay them as much as we can. I will also tell you that this for us has been the most important relationship and sometimes very trying. We did find that one of our nannies who had worked with us for 7 years was stealing from us pretty aggressively towards the end. And so while this feels like the person that you trust most in life and that you're leaving your children with, and it's the only way that you can be professionally successful, they're still not part of your family. And it's a very delicate relationship. So it's one where you do want to have a lot of trust, but you also have to verify what's going on. And we got very behind in checking receipts and making sure that everything that was being purchased was for our family, and it was not. So that was the lesson that we learned. And it was a very painful one to learn because we felt incredibly violated by it, that we had trusted our children to this person that was stealing from us. But it is still a relationship that we have to have now with obviously a very different nanny. So it's a very hard situation, but one that is critical to your success if you are in a dual professional couple. So make sure that you trust the people that you're working with. And if you find someone great, be willing to do everything to make that relationship continue to work. In terms of our family time, we try to really maximize that when we can. And this has been, since Dr. Haskins probably first saw this talk, very different over the years. When our kids were young, it was very controllable and easy, right? We had family dinner pretty much every night. Our kids were always home. They didn't have activities that were driving them in a lot of different directions. We've tried everything under the sun in terms of what to do for dinner. We've used food delivery services. We've done pickup services. We've given our nanny a grocery list. We've tried to go shopping, but that doesn't usually work. And so we usually bounce back and forth between either creating a grocery list for our nanny or doing some sort of food delivery service when we get stale and stagnant in what we're eating. But we always try and protect those night times as family time. So my wife and I have a policy that we really try to have no devices. So we're not on our computers, we're not on our cell phones. We're obviously answering pages if they come, but really trying to protect that family time until the kids go to sleep. And then after that, then you can turn on your computer and do work on talks and do other things. And we're not perfect about it, but as much as we can, we try to make that happen. Friday night was always like a protected night for a family movie night. Now we have 2 teen daughters and they go out on Friday nights with their friends. And so we watch a movie usually with our son. But again, you try and flex into what works for you and your family at the ages that they are. Weekends we really dedicate to our family, and a lot of times now that's sporting activities. So we're going to soccer games, swim meets. If we have free time, we try and play a round of golf as a family. Or if we have nothing scheduled, we try and take a weekend trip so that we can have some meaningful time away. We try to have individual parent-child experiences, and it's not always individual because we're unbalanced in a family of 5 rather than 4. But very frequently, like my wife will take my daughter somewhere and I'll have a father-son weekend, or we'll do vice versa. But it really, when you have 3 kids or even more than 1, you're just trying to figure out how to get some individual time with them to really get some meaningful time with one-on-one with your kids. We usually take about 3 weeks of family vacation. Before COVID, we were really good about that. We've been less good about it since, and are now that things are opening back up, trying to get back to doing that again. But spending time away from your work and with your family around the school schedule is really, I think, critically important. This absolute disaster is our family calendar. I recognize that in 2022, there are probably better tech solutions to this, but this is just what works for us. So everyone sort of gets a color. We put everything on the calendar. I showed you a summer month because like the school months are even worse. There's tons of school activities, but this requires a lot of upkeep. You have to make sure that things are up to date. Again, if there's a better tech solution, I'm all ears. This is just what's worked for us over the years. But we try to have everything kind of scheduled out so that everyone knows where everyone's going to be and where potential conflicts in terms of parental travel will come up. We have really tried to involve our kids in our professional lives. So when we have traveled to meetings or had opportunities to travel abroad for surgical purposes, we brought the kids. So my wife was fortunate to get this incredible fellowship called the James IV Traveling Fellowship, where she was the US traveler going to other English-speaking countries. And that fellowship paid a stipend to bring your spouse and your family with you. So we spent 2 weeks in Scotland, England, and the Netherlands, and another 2 weeks in New Zealand and Australia with our kids. And I had never been to New Zealand or Australia myself, and to be able to go with them was really fantastic. And they've come to surgical meetings when their mom was the president of the AAS and delivered a speech that really sparked a conversation about gender equity in surgery. Our kids were there in the upper left corner. And to me, it was one of the more powerful things in my life to watch my daughters be able to see my wife really start that conversation. So I think involving them in your professional lives is great. Other people get to meet your kids and see that they're hopefully good people. And it's great opportunities for them to see the world and to meet interesting people as well. So we've tried to bring them with us whenever possible. We do try to spend some time together one-on-one. We have a scheduled date night. We've always aimed to have that weekly. It never happens weekly. But if we aim to have it monthly, it would probably only happen yearly. So we still try and say one night a week. And that usually honestly means like maybe 1 to 2 nights a month we go out on a date. But those dates are great. Whenever we do that, we have dinner plus an activity. We'll go play golf, or we'll watch a movie or do something special, but really have some time alone away from the kids. When we travel to meetings, if we're going to surgical meetings together like ACS or SAGES or something else, we always make sure that one of those nights we just block off to be on a nice date night. And we try and find the nicest restaurant in town and we go. Because if you're going to be away from the kids, you might as well maximize that time. It's pretty rare that we travel alone because we travel a lot for work historically. And so traveling alone, we've really saved for like birthdays and anniversaries that end with 0 that are pretty special occasions. So up here is Paris for my wife's 40th. This was Napa for my 40th. And actually next week for my wife's, I guess I should say, second 40th birthday, maybe, we will be here in St. Lucia, which we are absolutely looking forward to. So blocking some time off away from your kids, I think, is critical to your relationship. In terms of maintaining your personal interests, it depends on what you like. So I love music. I play bass and piano. I try and play one of them every single night. I try and spend time going to live concerts when they were there before COVID and now after. I enjoy cooking. It's my way to relax. And so I come home, I cook dinner for our family, and I turn on music, and that's how I unwind from the day. I try to exercise. Unlike Dr. Prabhu, it doesn't seem to actually have any effect on my physique or my wellness, but I do think it's important, so I try. And I play a little bit of golf, usually poorly. My wife loves movies. She does yoga and tennis. She's an avid reader, so she reads pretty much every night. And she does enjoy shopping. And as sort of quid pro quo for my annual golf outing, away from family and away from her, she takes a spa trip with like her best friends from med school, away from me and away from our kids. So it's some personal time where we take a little vacation away from one another. I think the couple of keys that we have come up with is be all into whatever you're doing. So when you're at work, be at work, focus on work. Right? Leave home behind. And that means you have to trust whatever is going on at home, whether that's your nanny, your spouse, your in-laws, whoever takes care of your kids. Like, you have to have that level of trust so that you can be completely engaged in what you're doing at work. Similarly, when you're at home, be at home. Don't be thinking about what's going on at work if you can avoid it. It's very hard, but be present for your children. And to me, again, that means childcare is just the most important expense in the world, and figure out what's going to work for you, but check the expenses. We use our administrative assistants to be involved in our home lives. They will frequently find out when we are both traveling to some place and we didn't know we were both going to be gone at the same time. So put your family important things on your calendar so that your administrative assistant can watch for you as well, because they will pick up conflicts. This is our personal belief, I believe time is the most important metric in life. And so I spend my time doing what I like to do and what I'm good at doing. So I will never mow my lawn. I never shoveled snow. I don't want to do those things. I would much rather be at the hospital, take care of another hernia patient, and then pay someone else to do that. But if you love doing those things, spend your time doing it. So really maximize your time doing what you want to do. And for me, that has always been work or our family. For those of you that have children or want to have children, I cannot stress this enough. Take the longest maternity or paternity leave you possibly can. These are rare moments in life when you have time to be with your family, which is where you need to be. These are challenging times. It is a ton of work, but it is a ton of reward. And so maximize those when you can. The days of, I only took 1 week of paternity leave and then I was back in the OR, that is stupid. Be home and be with your family. And when you're at home, spend meaningful time at home. Like spend the time with them, reading them books, doing their homework, doing the things that you need to do so that at the end of the day, they remember you as their parent and not as a surgeon. But if you notice the cat pajamas that I know that one of my former trainees, Tori Arendelle, is on this call right now. She bought me those. They're super comfortable. So spend time at home comfortably. I think those are great. And I also like my tie-dye Crocs. Don't neglect your significant other, right? Of all the things that you do, like I've focused a lot on work and kids because that's a huge focus of my life. But if you let this relationship go, it can dissipate quickly. In between these two pictures is about 20 years of life. During those 20 years, we've lived in 4 different states. We've had 3 kids. We've had a lot of arguments, but there's an incredible amount of love and respect and admiration for one another. And our relationship is as strong as it was 20 years ago because of that. So make sure that you don't take that one for granted because you never know when that one might disappear, and that would be awful. And as Dr. Prabhu mentioned, you cannot neglect yourself. Our job is hard. It's challenging. It takes a lot out of you. It takes a lot of your passion and your time. And with the time you have left, make sure you're spending it doing what you like to do with the people that you like to do it with. So I think success and happiness are absolutely possible at the same time, but you have to figure out what works for you. And you have to readdress that with time because it's going to consistently change, and just be malleable and be ready to roll with the punches. Again, thank you very much. This has been an outstanding webinar, and look forward to the Q&A and the rest of the talk. So thank you.
Thank you so much for that talk, Dr. Greenberg. A few takeaway points for me. 1, I still love your talk. 2, you and your wife are the epitome of a power couple. And 3, Tar Heels are always better than Duke. Sorry.
False, but maybe true.
So moving along to our last talk, which I think, again, I'm just so appreciative for everyone's vulnerability and honesty during this session. And this is certainly a topic Dr. Jackson is going to get more into, but I think important for a lot of people as they transition into practice. And that is unhappiness in the workplace, especially after you feel like you've landed your dream job. So Dr. Jackson.
Thank you so much. Can everybody hear me?
Yes.
Okay, thank you. Thanks for everyone. This has just been an amazing panel of talks. So thank you, Dr. Haskins, for the opportunity to present on this important, but also anxiety-inducing topic. And I say that because even putting this talk together was anxiety-inducing for me, because in general, no one wants to talk about being unhappy. But also it can be really, really hard to admit that after working so hard to reach your goals, that things aren't going smoothly and that you're unhappy. So if there are any of you listening to this talk who are feeling this way, I know for a fact that you're not alone. And hopefully this talk will help those of us who are early in our careers feel a little more seen, a little more equipped, and a little safer talking about unhappiness and some of the ways that we can potentially manage it. All right, I have no disclosures except to say that the focus of this talk stems from components of my own story. And the suggestions that we'll talk about are based on what I've gleaned from this experience personally, and then what I've gleaned in speaking to other colleagues who have either experienced a similar situation or even those who've actually guided early career surgeons through some of its inherent challenges. All right, so true story. Overall, this is exactly how I felt when I was thinking about starting my career after training. I had graduated from a great residency. I got amazing training and mentorship and fellowship. And that set me up really well, honestly, to do everything that I thought I was supposed to do in a job search. I researched the programs, I interviewed at multiple institutions, I talked to colleagues who'd been through the process, and I negotiated. And then I signed at what I thought was my dream job at an academic center. And I really felt like my life professionally and personally was really just beginning, with a lot of excitement for the future. Fast forward a few months into the job, where I felt like the reality of my job was far from what was advertised in terms of responsibilities and in terms of mentorship from senior partners. And this trend continued to the point where I felt so unsupported that it actually started to affect my confidence in my surgical abilities. And I felt very anxious about my future in surgery. And after some guidance and really just a stroke of luck that the opportunity came when it did, after about a year, I made the often ill-advised lateral move back to my home institution. And though I was pretty grateful for the opportunity to go back to the place where I had transparency about the pluses and the minuses of the program, it was hands down, the most stressful and sad period of my career to date. And while the nuances of my story may be specific and unique to me, the essence of the story is not. There are many common themes in what I just said, and that's led to more than 50% of surgeons leaving their first job within 3 years. And actually, there's data out there that suggests that up to 70% will leave within 5 years. So even though I feel like I could probably do one talk on each of these bullet points here, we'll spend the remaining time just talking about why early career surgeons specifically are at risk for unhappiness. And then I'll share some ways that I think we can manage it. So this is kind of a busy slide, sorry, but there are numerous reasons early career surgeons are at risk for unhappiness. These are just a few that I'd like to highlight, and they really aren't in any particular order, and some of them have been talked about. So for many of us, the stress of ultimate OR autonomy, right, the thing that we've wanted since residency and fellowship, can ironically place us at risk for unhappiness if we aren't in a supportive environment. The exponential learning curve, and sometimes this is our actual first direct experience with our own hands causing complications. And that can be a tremendous cause of stress, anxiety, and unhappiness. Similarly, our first years are really kind of our first intro into the realities of building a surgical practice. So things like handling complex patient care, understanding billing, but also navigating barriers to building a practice, like sometimes inadequate admin support, or the dreaded competition or lack of support from senior partners that can lead us to feel unsupported, and that can also lead to unhappiness. Additionally, just a lack of focus for career development. So this is one of the first times in our careers that there really is no exact playbook to follow in terms of how to be a good attending. There's lots of stuff about what we need to do to get to residency and what we need to do to a checklist of what we need to do to match in fellowship. There's really not that checklist for attending life. And most of the time we're only taught how to get to attending life, and we're rarely encouraged to meaningfully think about what we actually want our attending life to look like. And in addition to that, formal guidance on how to navigate life as an attending can be rare. So that all can set us up to be literally all over the place in our careers. And I think that's a setup for unhappiness. I put minority tax here because I thought it was worth talking about. So this refers to kind of the extra responsibility that's placed on minority faculty in the name of efforts to achieve diversity. And I put this here because junior faculty can often be placed in and ironically asked to even head these roles early in our careers, regardless of if this work actually aligns with our passion. And while institutions and departments should really be mindful of this before asking us, and they really should ask us if this aligns with our goals, our work as young surgeons is to be radically honest with ourselves and our department leadership about whether this aligns with our goals. And we can either decline the opportunity right outright, or if we take the opportunity, we should speak up if and when we realize that it actually doesn't align with our passions, so that you can transition out of that role to allow for things that do align with our happiness. The last two, the kind of put your head down and push through mentality that pervades surgery and honestly all of medicine. This can be really harmful and harmful for our overall wellness, harmful for our sense of happiness. And early on as a new attending, I think there's a lot of external and sometimes self-imposed pressure to not want to admit how hard all this can be. You don't want to complain, and you ultimately want to, quote unquote, earn the respect of your partners and your colleagues. And I think this really underscores the importance of assessing and asking about the culture of a program in the interview process, and choosing a program that de-emphasizes this mentality and rather emphasizes collaboration, mentorship, and the recognition that we're all in this together and we're all doing hard work at all levels. And then finally, this is really self-explanatory, so I'm not going to spend a lot of time on it. Just regular old general life, but also important stressors like family, finances, and societal expectations and responsibilities that are placed on us as we're newly out in the workforce can also lead to stress and unhappiness. So these are all things that place us at risk. What can we actually do if we find ourselves in a situation where we're unhappy? I honestly think self-reflection is the first crucial key and honestly the most important step in obtaining happiness in our careers. And I think we've heard themes of that throughout all these talks this evening. This requires some real quiet alone time with yourselves to ask yourself some really important questions. So ask yourself, what's working in your current situation? What is not? And then really sit with, what does happiness or success look like to you? And I felt like really when I was an attending in my first job, that was the first time I ever actually felt like I had the breathing room to actually even think about, what does happiness look like? I felt like I had been just on this train of checklist this, checklist that, because of the nature of medical school and residency. But it's really important even now in residency and fellowship to try to think about, what does happiness look like for you? And when you become an attending, to think about it immediately and understand that that may change. So once you understand that, you can start to think about what professional or what personal things that you can shed that doesn't align with your happiness. And you can think about it in stages. What can you shed immediately? What can you shed in 6 months? What can you shed within the year? And you can also think about, what would you like to add that does align with your happiness? What can you add immediately? What can you add in 6 months? And what can you add within the year? Once you've spent some time reflecting, then it's time for us to kind of step into our power. And I know that may sound cliche, because for many of us, actually advocating for ourselves can be one of the most daunting and honestly uncomfortable things that we do. And that's saying a lot because we're surgeons, but it can be, particularly for those of us that are just out in practice, or for underrepresented young faculty. This can be very daunting. And yet I still firmly believe that it is necessary in the journey of professional and personal happiness. And so once you've reflected, it's time to advocate for yourself by having a frank discussion with your leadership. When you sit with them, I would talk about, in your view, what are the departmental barriers to your success? How can the department support your success? And once you've had this discussion, before you leave the meeting, discuss a time frame and a follow-up discussion on your concerns, understanding that sometimes change will take time. Of course, your concerns aren't the only concerns of the department, but even in that, it's still important to hold yourself and the department and your leadership accountable for changing things that aren't aligning with your success and that aren't aligning with your happiness. All right, while you're stepping into your power, I think it's also important, to utilize your resources and networks to find allies and advocates. Call your residency and fellowship mentors to ask their advice. They've been invested in your success for years, And if you found them to be supportive during those periods, they'll likely have so much advice and perspective that you may find useful as you navigate your difficulty. And they'll do it without judgment. I remember when I reached out, I was so almost ashamed to just admit that I've been having a hard time. And there was absolutely no judgment, which told me that they were the right people to talk to. For those of you who are at your home institution and you feel like you can't talk to the senior people there, recognize that you may need mentorship or peer support outside of your department in your institution. One of my best leadership mentors is an emergency medicine physician who I've known since I was a medical student. And her advice and outside perspective was really invaluable during some of my early career anxiety. And then, of course, I still talk to my fellowship mentors monthly, which I'm super grateful for. And then lastly, kind of thinking more broadly, like webinars like this or national meetings and social media, those can all expose you to leaders and peers who have a wealth of knowledge, a wealth of perspective that can be useful. So don't hesitate to reach out, especially when people offer their support. And then lastly, I'm wrapping up so I can stay within time. Sometimes, ideally, when you've done all the previous things that we've talked about, the best situation will be for you to move on from that situation. And, despite some of the common themes, it will be a uniquely personal decision when you realize that it's time to move on. For me personally, my main consideration was my operative development, my growth, and my confidence. And despite my nervousness, I immediately felt that it was the right decision once I started back at my home institution. And honestly, when I look at the surgeon that I am now, I absolutely know that it was the right decision. And so when you personally decided that it's time to move on, there's some things that I would remember. First, this is not a failure, okay? Give yourself grace and understand that you made the best decision in that moment with the information that you had. From there, use your experience and help make and allow yourself to make a more informed decision for the next job opportunity, right? Step into your power in the scenario and really ask the hard questions in your next interviews that you may not have either known to ask as a newbie out in training, or you may have been too scared to ask or too timid to ask. Now that you understand exactly what you're looking for, and you've experienced something that made you so unhappy, be clear on your priorities before you interview and articulate them during your job search process. Next, once you've made the decision that you need to move on, be sure to review your contract just to help you understand what your timeline might be, and help you understand what your options may be locally and regionally. From an exit strategy standpoint, as in anything professionally, respect your boundaries, yet you want to also work to avoid burning bridges when possible. So do the right thing for your patients and colleagues until your last day. How you leave definitely does matter. And then lastly, I think this is important. Use radical candor when people ask you about your experience. So radical candor goes against this kind of long-standing tradition or teaching of if you don't have anything nice to say, don't say it at all. And rather, it really focuses on open and honest feedback for the benefit of everyone involved. And so I honestly think that speaking honestly and speaking frankly honors the reality of your experience, and it allows you to pay it forward by helping somebody else make a more informed choice. Or honestly, if you're open to it, you can also help the program improve the experience for the next person they hire. So radical candor is key because people will ask you about your experience, and it's important to be as honest as you can. All right, almost over time. So lastly, my take home point. So early career surgeons have unique risks for unhappiness. Self-reflection truly is the first key to obtaining happiness. Step into your power with self-advocacy and communication with your leadership. Ask your network of allies and advocates for help. And then lastly, moving on is definitely okay. honor and use the experience as a stepping stone to the career that you want. Here's my contact information. You guys can reach out to me either virtually or either on social media or via email. If you want to talk more about my experience or you want to share yours, I'm happy to lend an ear and give some additional advice. Thank you so much again for the opportunity, and I hope this was helpful.
Thank you so much, Dr. Jackson. You have provided me with radical candor for years, and it's been so helpful. So thank you. And I just, again, want to give a great round of applause to all of the panelists. You guys were vulnerable and raw, and your personal experiences will certainly help those who are transitioning into practice. I have a lot of takeaway points from this webinar. So thank you again for being a part of it. When I was putting this together, you guys were the first people I thought about to talk about these topics. So again, thank you so much. There are a few questions in the question and answer. Some of them have already been answered. It looks like there's one new one. It looks like Dr. Greenberg wants to answer this one. So Dean is asking, can anyone shed light on the pros and cons of being an independent contractor versus a hospital employee as a general surgeon?
I accidentally clicked a button. I don't actually know what the difference between those two things are. And I think Dr. Halbert might be way better equipped to answer that than I am.
Yeah, I mean, that's a hard one to answer because there's a lot of pros and cons to both of those things. I mean, being your own boss, you can't lose by that. And having flexibility in your schedule is actually one of the #1 predictors of satisfaction for physicians in general, not even just surgeons. So you have the independence to move about, and have your own flexibility, but at the same time, you don't have the same coverage that an institution can give you. So being hospital employed, they're paying for your malpractice, a tail, things like that. And you have to do that on your own if you're otherwise, outside of an institution. So there are a lot of pluses and minuses, and each contract that you're looking at has to be, weighed carefully. This is a really in detail conversation that needs to be had when you're really considering both of those things. Dr. Wright, do you have something to add to that, maybe?
Yeah, I was just going to add, and this is true about any job that you're looking at. Something that I don't think many residents think about is the benefits. Everybody looks at the top line of the salary. And when you think about maternity and paternity leave, when you think about illness leave, when you think about disability, own practice disability, when you talk about health insurance, retirement contributions, these are things that actually are massive. So for example, my personal job, if you look at my top line, what's my salary? It's actually relatively low. I'm at like the 25th percentile nationally. But I have incredible retirement contributions, which actually almost makes up that difference to get me to the 50th percentile. And when I had cancer, I could take 3 months off and I saw no change in my salary because I was an employed physician. If I were an independent contractor, those 3 months, I would have had no income. So that doesn't mean that being an independent contractor is wrong. It's just you have to know that the importance of those benefits and what those benefits really mean to you from a financial and really lifestyle standpoint.
Yeah, absolutely. And I think that's why I mentioned about private practice, being out there on your own, it's a very expensive endeavor. And you really have to know what you're getting yourself into, and partnering with somebody who has a really strong business sense, if you don't have that, is going to be vital to making sure that your new practice is successful. So, there's a lot of things that we don't anticipate as physicians because we don't have that education and background, and we want to make sure that either we educate ourselves or we find people that are.
And I would piggyback on that latter point in that I know nothing about business or law, but I know that I can hire a financial advisor and a lawyer who do. And so when you're negotiating a contract, like there's a lot of legalese in those things. You are not going to be ready to read those. And so while it feels like a big investment at a time where you don't have a lot of money to invest, hire a lawyer. It's critically important. And then even if you're not making money yet, you will be in the future, and having a financial planner that can help you make good decisions with it is also very important as well. And so I think outsourcing those things that you don't have expertise in is a very important thing, because again, unless you want to spend time like studying the market and learning what to do, if that drives you, do it. But if not, just pay someone else to do it. It's way, way better for you to use your time doing what you do and pay someone to do what they do well, which is manage your money.
Okay, there's another question asking about managing your social media presence. Do any of you have quick tips or resources that you would recommend?
I think all of us have a pretty active social media presence. One thing I'll say is it actually starts not with social media, but with just your online presence. So if you type in any physician into Google, it's going to pop up all of these links. Own those links. Make sure the information is accurate, because your patients are going to try to find you that way. I found out, I didn't know this for years, and my profile said I was a gastroenterologist. Like, unless you go in and say, claim that business, like my business is Andrew Wright, MD. And I set up like a Google alert. So if something pops up with my name in the news, I get an email about it. Like that's the first step, making sure like vitals.com and your hospital website has the good information that actually says what you do, what your treatment philosophy is, what insurance you accept. That's like the bare minimum. And then social media is sort of a bonus on top of that. I think a lot of us use that more for interprofessional communication and less patient relations kind of stuff. But I have patients that come in and they saw me on Twitter and they know I operated on a gorilla because they saw it on Twitter. I mean, it's like, you know.
I would add, make sure you Google yourself often, so you know it's out there, and then also keep your professional and your personal social media accounts separate. That is something that I found has been very helpful. My personal account doesn't have my entire name, but my professional account does, because patients will be looking for you. And now I can invite them to actually find me on Facebook and friend me, but I keep those accounts very separate. I don't want them knowing that I was at a concert this weekend. Do you know what I'm saying? Like, they don't need to know all the details of my life. And so you want to keep those things separate if you can. Because patients do research on you, and we all know what that research is. It's a Google search. So you want to make sure you know exactly what's out there on you.
Another thing I would add is just making sure, a lot of times the university that you work, the institution that you work for will have a policy on social media. And I think it behooves you, before you do anything, to understand what the university policy is, because I've seen lots of people get in trouble just because they don't understand that. Not that they're necessarily posting something terrible, but they don't really understand the nuances of the policy. And then you always just want to be mindful about patient privacy. So a lot of times when you are, you had a really tough case or you had a really amazing case, sometimes you may want to just tell the world, but you have to be mindful about posting that. So typically wait maybe 48, a few hours or a few days actually before posting about this, just to protect patient privacy, because that can be identifiable information if it's something that's so rare. So just be mindful of that.
I agree. And I would say particularly in the operating room, since we're all surgeons, I think particular institutions have their own specific kind of guardrails around what you were allowed to post and what you were not. And I think in my facility, I'm pretty sure you can't post something that has your name badge while you're in the operating room. Like, that cannot be on social media, even to the extent that I do think that like people can lose their jobs over it, kind of thing. So you want to be real careful, and particularly those who are in training, who are medical students or residents, because you are so enthusiastic and you're so excited about it, but you want to just be careful that you protect yourself so you don't get in trouble inadvertently.
You're muted, Ivy.
Sorry, next question. This is a good one. This is asking, sorry, did it go away? Where did it go? Answered. There is one, they were asking, okay, My first year in practice, my only partner, who's 7 years senior to me, is making my job miserable. I was hopeful for a mentor, but we are clearly competitors as our contracts are heavily tied to productivity. Does anyone have any advice on how to repair a professional relationship and work through this?
So that's one, I'm sorry, right? That is not the situation you want to find yourself in. There's a great article in the Harvard Business Review that like reviewed 4 different relationships that you can have with people. And it's like friend, enemy, ally, foe. Your friend is your friend through and through, right? They will always be with you no matter what, whether it serves their best interest or not. Your ally is someone who will be with you when it serves their best interest as well. A foe will not really be with you for anything, but an enemy will be arduously against you in everything. And so I think trying to figure out where on that spectrum you are with this person might be critically important. Like if you can find some common ground that will be mutually beneficial for both of you, where they might ally with you, would be a helpful start. If you can't find that, it's probably not going to work. So I think if you can find some common ground, building one clinical program where both of you could prosper and you can work together, that's a great way to try and rally them. But if not, it might be reasonable to start thinking that this relationship will not work. And I can't remember what was candor. What was the amazing term that Hope just used? That was so good that I really want to start
candor.
using.
Yeah,
yes,
radical candor. Yeah.
Time for radical candor.
I think sometimes that's also when having a lawyer look at your contract and figure out what the actual responsibilities are and what your actual recourse is. It could be pretty important because every job is different, and knowing those details can be important.
And again, I guess I would just add, it's your first year in practice. One of the best pieces of advice that I got was, early on in your career, this is when your confidence is developing and when you are gaining some of your confidence. And I think if you don't feel comfortable going to this person to ask for advice, you could find yourself limiting what you do because you know that I can only get myself out of this situation. So I'm only going to do like 3 cases. And I say that because that is exactly the situation where I found myself in. And that was not going to be the way that I grew surgically or professionally. And so I think I would really look at what your practice looks like. And if you really don't see a way to find some allyship or find a common ground, and think about what you want to do. You've worked really hard to operate and take care of patients. And I would hate for your first few years for your confidence to be so damaged that it changes the trajectory of what you may do, and you have to spend years rebuilding it.
Yeah, and I will also add that, a lot of contracts, especially in community practice, have some terms set to them. So if you leave within 2 years or 3 years, for example, you may have to pay something back. And so you want to be really careful about the timing of if you are going to leave, what that's going to look like. And also your non-competes are really important to be looking at on the way in and also on the way out. If you're kind of stuck at that position for more than a year, let's say 2 years, 3 years, you want to figure out what needs to be done to work this out over that time frame, whether it's working in a different market than that person, working, in a slightly different subspecialty. So if that person does more bariatrics, maybe you take on more foregut, for example, or something else that you can find your niche that's not going to be in direct competition while you're still growing your practice. So there are ways to work around, and everything's, everyone is, this is kind of, I'm painting a very broad, with a very broad paintbrush here, but I think that, you really want to look to see if and when you need to leave, and then what can be done in the meantime to make it workable for you.
So someone brought up in the comments that, leaving your first job, and, Dr. Jackson's talk was very brave, right? But it sometimes can be the first time that we're failing, right? So we've made it through med school, we've made it through residency, we've made it through fellowship, and we've all achieved these, kind of benchmarks or important kind of stepping stones. So can you guys all just sort of give me or give the panelists or the people listening a little bit of advice, like what, obviously not every person leaves their first job early. So failure is something different to every person. It may, for example, be a complication like Dr. Prabhu showed. How do you guys manage that in your first year when you're kind of transitioning to practice, you're figuring out what happiness is to you, and you're trying to find that work-life balance and trying to give back to yourself?
Yeah, I can start on this one. I think for me, it was really having that network around you, both at your current job, but also from residency or wherever, of people you could call when things didn't go right. And most people, as we've heard from all the panelists, have had some sort of experience like that. And so for me, like even now, if something doesn't quite go right in the operating room or with a research thing or whatever, I know exactly who I can go to and talk to, who will be able to kind of not only provide some empathy, but also some potential solutions of like, how can I grow back from this? Or how can I, improve so this doesn't happen again?
I can go next. I would just say I had 4 different jobs in my first 6 years of my career. So I've been through this a couple of times. And I would say, it's the hard cases, it's the complications, it's everything that is conspiring to kind of work against you, no matter how hard you're running. And the thing I would say that has gotten me through most of it is sort of a consistent belief in, number one, not making big decisions when you are in the wrong place to do it. So if you are emotional, if you are tired, if you are under duress of some sort, if you are drinking alcohol, like those are not the times to make big decisions about your career. Those are the times where I will lean more into healthy habits and trying to get rest and trying to get myself to a steady state so that I can decide what to do, first of all. Second of all, I agree, talking to mentors. And third of all, the one thing I will say is, there's often a discussion about where you want to be in 5 or 10 years. And I just haven't found that to be useful in my life because I think it can put blinders on to opportunities as they come. So for me, I've tried to find a place of sort of, I think Hope said this quite well earlier, a quiet place of reflection to get there and say, okay, maybe it's not going so well right now, but generally speaking, my judgment is reasonable. So within that, what do I know? What are my liabilities? What are my assets? And what do I want to do? And I usually trust my instinct at that point, and eventually the right thing will occur. So I would just say not losing your own confidence in your ability to make decisions. That's really important because you can feel gaslit. You can feel like everybody around you is doing well. Why aren't you? It's really hard to work through that. So just being quiet and listening to the voice in your head can be very helpful.
Just to continue on with that, I think there's a stigma attached to the idea of therapy. People don't talk about it enough. I would say about 3 years into my practice, I was really unhappy and struggling, and it mostly manifested at home. But really, that was a reflection of my work. And it was me taking my work home and compartmentalizing it. Therapy really helped me work through that and realize that it was my issues in balance and communication at work. And then I had to go and talk to my boss and actually reframe what my job looked like. And in retrospect, what I needed was actually a coach more than a therapist, which is why I now recommend coaching to a lot of my mentees. But I don't think we talk about that enough as surgeons. We're sort of too tough to talk about it, but it's important to recognize that.
Yeah, so I will pile on top of that. I was at my first job for 10 years. And honestly, if it weren't for my wife being ready to take her next job, I would have happily stayed there for another 10. Like I was thriving. I loved my practice. I loved my academic opportunities. I had exactly the job that I wanted. But I also had a wife who had a need for a new job for her. And so we took a second job where we were at for 1 year because it was awful for me and okay for her. And I think to deal with that, one, I turned to some of the people on this phone call, right? I've had conversations with Dr. Wright and Dr. Prabhu about this, who provided great insight and said that they were sorry to hear that I was unhappy. So you reach out to your professional colleagues who can provide you with great insight about what's going on. But I also had an executive coach who, honestly, I couldn't tell if he was a coach or a therapist. He really functioned as both. But Dr. Wright's totally right. Like, I was short with our kids. It got to the point where our oldest daughter, who was a teenager, we moved her in 8th grade and then moved her again in 10th, said, like, I don't care if I have to move again. I want my dad back. And when I heard that, I recognized that we had a serious problem, and that my unhappiness at work had not only come home, but it was like creating serious problems at home. And that was no longer okay. Because for a teenage girl to be willing to move in 10th grade to have the relationship with her parent back was very hard to hear, and still something that I feel very bad about. And honestly, leading that job felt like more difficult than it did leaving the job that I loved, because it felt like quitting. And it's really hard today, still, in a job now that I love and will hopefully have for the next 10 to 15 years, but it was tough.
I'll just add just really quickly, I don't want to echo everyone's comments, but yeah, I think it's important, whether it's therapy or coaching or your colleagues, to talk about this, because I do think that we can gaslight ourselves and think that everyone else is doing great. And most of the time, everyone else has similar struggles or has experienced something similarly. And so we just need to talk about it. And I felt like once I was able to talk about it, and for me, the biggest hurdle was talking about it to, one of my fellowship mentors, that felt like, oh gosh, like he's going to be so disappointed. And once I was able to get that off my chest and have him say like, this is common, and I was just like, oh, wow, this is okay, great. I felt so relieved. And so I think talking about it and just getting rid of that stigma will really help you kind of recenter yourself, reflect on what's important, and then move forward to make the changes that you need to.
Yeah, I think everyone really hit the nail on the head here. I mean, the therapy and coaching and talking about it and having your team. But I think also recognizing that when we come out of residency or fellowship, we have one very narrow view on what practice is. And, you think that like, oh, this job's going to be perfect and it's going to be exactly how I envisioned it. It's okay if it's not. It really is. I recognized that 1.5 years into my first job and was gone by the end of my 2nd year. So it's just, you just think it's going to be something, and you just don't know. You don't know all the different things that are out there. I mean, that's why, having this tonight and learning about different practice types and, different things that we kind of step into and we don't realize that could be good or bad. You really want to try to think these through as much as you can, but even with the best intentions, you don't know really what's out there. So sometimes you do have to go through a couple different jobs to get to the one that really is meant for you.
Such good advice, you guys. The one other thing I'll add, and I just talked about this at the fellows course a few weeks ago, is happiness. What you think is going to make you happy when you start is not necessarily what you think is going to be happy 1 year or 5 years or 10 years in. So give yourself some grace and recognize that sometimes your goals have to change. And if that's not working at your institution, it's not necessarily a failure. Again, I just want to say thank you so much to our panelists. We're running out of time. Of course, great discussion at the end. But again, I just really appreciate your guys' honesty and kind of inviting everyone in, giving them a glimpse of what it's like in your guys' lives. And again, I'll just say, as Dr. Greenberg pointed out, he looked to other members of this panel for support when he was going through tough times. And this is really, what SAGES has to offer. It's my favorite professional organization. Everyone on the panel today, I can call a colleague and a friend, and I'm so appreciative for you guys and your participation in this panel. For the participants, there is an end of the webinar questionnaire or survey. So if you can please fill that out, these are meant for you guys as trainees. And so we're always looking for new topics and ways to make these better for you guys. So if you wouldn't mind filling that out. Thank you everyone again for attending. And again, to the panelists, thank you so much and have a good night, everyone.